Welcome to NOAHE Rounds 9, Session 1. I'm Dr. Erin Kerwin, Senior Principal Economist at IHE, and I'll be facilitating today's session. I'm also joined by my colleague, Dr. Leslie Sorrell, who's also a Senior Principal here at IHE, and Leslie will be moderating the Q&A. So I'll begin with a land acknowledgement. In the spirit of reconciliation and gratitude, the Institute of Health Economics acknowledges that what we call Alberta is the traditional and ancestral territory of Treaty 6, 7, and 8 regions, and the Métis settlements, and the 6 regions of the Métis Nation of Alberta, whose histories, languages, and cultures continue to influence and enrich our community. So please join me in welcoming our presenter, Dr. Michael Law. Dr. Law is a professor in the Department of Community Health Sciences and the academic director of the Center for Health Policy at the University of Calgary. His research focuses on pharmaceutical policy, the affordability of prescription drugs, and the use of administrative data to evaluate policy. With the funding from CIHR and other major funders, his work has been published in leading medical and health policy journals and has also received significant media attention. His interactions with federal and provincial policymakers have informed major policy changes that improved access to medications and reduced drug costs in Canada. He was previously a visiting scholar at the Harvard Medical School based at the University of Rwanda, which has led to ongoing projects in several lower-income countries. He holds a PhD in health policy from Harvard University and an MSc in health, population, and society from the London School of Economics. So today's presentation topic is the impact of deductibles in the British Columbia Fair Pharmacare program, and that's 3 quasi-experimental studies. So income-based deductibles are present in several Canadian public drug plans and have been the subject of extensive debate. Dr. Law and colleagues studied the impact of the deductibles used in British Columbia's Fair Pharmacare program on drug utilization and health resource utilization. They used 2 quasi-experimental regression discontinuity designs to study the impact of deductibles using over 1.2 million person-years of data. Following this, he will also discuss a subsequent interrupted time series analysis of the impact of the removal of these deductibles for lower-income households in 2019. The results will demonstrate that deductibles represent a barrier to accessing prescription drugs for some households, and that their removal leads to increases in drug use across different classes of medications. So before we begin, I'd like to go over some event housekeeping. First, participants will be muted throughout the webinar, so there'll be no cameras and no mics. So if you want to submit any questions during the webinar, please use the Q&A function. The Q&A function is different from the chat function, so please ask questions. You can do so at any point during the seminar, but ensure that you're using the Q&A button to do so. And finally, we'll go over the Q&A answering your questions for the last 20 minutes of the webinar. So thanks again, everyone, for joining us. And I'll now hand over to Dr. Law.
Aaron, thanks very much. So thank you all for coming, and I'll put my slides up. As questions arise, please write them down. I'm happy to engage in a conversation, and then happy to, at the end, go off on any tangents you want. I was at UBC for 16 years and studied Fair Pharmacare for a long time. So this is a bit of a flavoring for the work that we did there, but it's not all encompassing. So I'm happy to talk about what BC's drug plan looks like and how it operates. So I'll share my slides here so that you can all see them. And as Aaron suggested, I'm going to be talking about 3 quasi-experimental studies. So 3 different papers that we wrote looking at the Fair Pharmacare plan, 2 of which use a regression discontinuity, 1 of which uses an interrupted time series analysis. So in terms of an overview, I'm going to introduce the BC Fair Pharmacare program, at least in a very sort of light touch way, so that you get a sense for what the program looks like. It's quite different from the public drug coverage that Alberta has. And then, as I said, I'll go through 3 studies. The first is going to look at the impact of the deductibles on older adults. The second one will look at the impact on lower income households. And the third will look at how changes that BC subsequently made for lower income households impacted drug use. So Fair Pharmacare was introduced back in 2003. So this is Colin Hanson, who at the time was the Minister of Health, and this is him announcing the policy. So BC moved from a prior policy that was much more, much similar to what other provinces had. So there was an age-based coverage program that provided very generous coverage for seniors, and then far less generous coverage for those who were under the age of 65, because most of that would fall to individuals with private plans. But in 2003, the government shifted to this model here, which I'll sort of lay out for you. There's different coverages in Fair Pharmacare based on whether you were born before or after 1939, and that matters because you were in 2003, if you were born before 1939, you were 65 or older. So there's essentially better coverage, or what's called enhanced coverage, for the households that have one or more members who were born before 1939. And the way that Fair Pharmacare works is for drugs that are on the formulary, you get coverage after you exceed a deductible and then a household maximum. So for example, if your household income was between $0 and $14,000, you were had a household member born before 1939, you would pay no deductible, so 0% of your household income out front, and then you would pay 25% of the cost of your drugs up to a maximum of 1.25% of your household income. And you can see as you get higher in income, these numbers change. They don't if you were born before 1939, but once you exceed $30,000, you pay a 1% of household income deductible and then a co-payment of 25% up to a maximum of 2%. So that's the enhanced coverage. That's folks who were 65 or older when Fair Pharmacare was put into place. If your household was all born after 1940, your coverage is different. So 0 to 15,000, you had no deductible, and then a copayment of 30% up to a maximum of 2% of household income. So if your household had an income of $10,000, you would pay 30% of your cost of your drugs up to a maximum of $200. Between 15 and 30, you had a 2% of household income deductible. So you would face the full cost of your drugs up to 2% of your household income. You would then pay 30% of the cost up to a maximum of 3%. And the final threshold here is that there's a deductible 3% up to a maximum of 4% after that copayment. So I hope that description is clear in terms of how it works, but essentially most households in the province are going to fall here. So they're going to have public coverage that kicks in after you hit 4% of household income. There's a couple of other features that are important. Fair Pharmacare acts as first payer. So if you have private coverage, all of the amounts you pay either out of pocket or through your private coverage will count toward that deductible. And then also BC Pharmacare, it covers everything. It's first payer, and private insurance counts toward it. Those are the two things that combine them into one for you. This had a really immediate and probably pretty dramatic effect on drug costs. If you look at BC Pharmacare over time, you can see that there's a little bit of a tick downward in terms of those increases over time in terms of public expenditure. Part of the goal here was to limit public expenditures. And so the overall goal, and there's been a lot of work by folks to look at this, was that the trajectory of drug costs did decline after Fair Pharmacare was put into place. One other consequence, though, was that when you look across Canada at the rates of folks that can't afford their prescription drugs, this is from a paper that we did back in 2018, looking at patients reporting cost-related non-adherence. BC comes out as the highest in Canada. And one of the places where the blame would fall for this is on the public drug plan. So is this plan generous enough to avoid people having to forego medicines because they can't afford them? And there's been a lot of discussion and sort of debate about this. I'll highlight two reports that were kind of written in the mid-2000s, or in the sort of 2010 range, one from IRPP and one from the CD Howe. And different audiences and different assessors come up with very different conclusions about the impact of Fair Pharmacare. Full disclosure, I was an author on the IRPP piece, but I think the juxtaposition of these two is quite telling. So the IRPP piece concludes, overall, the theory and evidence indicate that income-based public drug plans are not designed to achieve their key policy goals, access to medicines, financial equity, and system efficiency. So you can see a very sort of negative view. Whereas CD Howe, an assessment of plans like BC, said, on balance, we find that the benefits of an income band place make them superior to age-based ones. So they're arguing that a plan like BC is superior to a plan that would look more like, say, Alberta or Ontario. All this to say that when we talk to policymakers about these design features, they're left with kind of this feeling. Pretty unclear on what the results of these plans are and what they're doing in terms of either making households more or less able to afford their prescription drugs. So we dug into this during the time when I was at UBC through a series of papers. The first one that'll lead you to, so this is the piece we published in CMAJ back in 2017. And we looked at the impact of income-based deductibles, so the BC drug plan, on drug use among older adults. And I'll make it clear why we chose older adults here in a second. But so this piece, several public drug plans use income-based deductibles. So there's a lot of other provinces that have these kind of designs, Manitoba's being the most similar, but Ontario, for folks under 65, it's an income-based coverage plan, and there's others. So a lot of plans do this. So in BC, as I showed you in that first chart, sort of 3 to 4% of household income is kind of the threshold for what most households have to spend out of pocket before public coverage kicks in. So the question in this piece was, what's the impact of these deductibles? What are they doing on drug use and use of other healthcare services? So are the deductibles impacting how much healthcare folks are accessing, both within the drug plan and in other parts of the system? And for this, we used a regression discontinuity. Given this is a health economics group, I'm sure you're probably all familiar with what a regression discontinuity is, so I will move through this fairly quickly. Again, we can revisit this when we're going through the questions if there's an interest. But the design in a regression discontinuity is essentially you compare the trends in an outcome above and below a threshold in a forcing variable. And I'll make it clear what that is in a second. And then the counterfactual is that the existing trend above and below that threshold would have been smooth had there not been a change. So to sort of draw it out, the outcome of interest here, in this case, let's say it's drug costs. So how much money folks are spending on prescription drugs. And the forcing variable here, you've probably guessed since I'm doing older adults, for those of you who know the method, this is going to be whether you were born in 1939. And it's going to go down on the left and it's going to go up on the right. But this line here represents 1939, because you can imagine on this side, when households are older than being born in 1939, so if they have a member born in 1930, they have better drug coverage here than they do here, because they are facing those lower deductibles. And then what you look for is changes at that threshold. So the assumption is that nothing else changes across being born in 1939, apart from the drug coverage that would impact drug use. So it's a big assumption. We could talk about whether that would hold here, but that's really the assumption. So to draw that out on the chart here, you can recall that 1939 is sort of that magic year for fair pharmacare. And what we focused in on was these two groups right here. So the group between $14,000 and $30,000 of household income on enhanced coverage and 15 to 30 on regular coverage. For research purposes, I really wish they'd made that 15 on the left-hand side, but they didn't. We're kind of unable to differentiate the two of them, unfortunately. But if anything, those lower income folks would bias us toward not finding an effect, because those households would be in the group that we'd expect to have more better drug coverage, or more trouble of affording their prescription drug. So you can see the difference here, though, is that as soon as you cross that threshold, you go from a deductible of nothing to a deductible of 2%. And the maximum, you go from 1.25% to 3% of household income. So just by virtue of being born in one year versus another, your public drug coverage changes pretty dramatically across that threshold. So we use the BC administrative data. For those of you who are not familiar, BC has an administrative data system called PharmNet that collects data on every prescription that's dispensed in the province. It'd be similar to Alberta's PIN system. It also includes data on household income for households who are registered with Pharmacare. So about 60% of households at the time were registered, which means the province has permission to go and obtain their tax data from the CRA, and they use that to put people into these different coverage groups. And then in terms of the outcomes, we looked at the number of prescriptions and expenditures that households had, or that individuals had above and below those thresholds. We looked at the number of hospital days and admissions and physician costs and visits. So we used the DAD and the MSP for the latter two. And MSP is medical services plan. So I'm forgetting that I'm not talking to a PC audience here. So just to sketch out how this looks in terms of our population, we have about 865,000 people who were born between 1928 and 1951. You see, we took a span of 12 years on either side of the threshold. And our unit of analysis here was the person year, because each person, the deductibles work on an annual basis. Your deductible and your co-payment maximum gets reset in January, and then it goes for the entire year. So everyone gave on average about 10 years of person data to our analysis. So we had 8.5 million person years that went into that we started with. We then limited this to household incomes that were between $14,000 and $30,000 to get that sort of core central group that I was talking about. We required that people were in the same plan for the entire year. So if people move income bands, they can move coverage levels. We restricted it so that they could not do that because we weren't sure what that would mean. They had to have no claims under a more generous fair Pharmacare plan. So that would be most commonly things like social assistance. And those give full coverage for prescription drugs. So again, would have confounded the effect. And we only took the oldest person in the household. So because the 1939 number applies to the oldest person in the household, we only analyzed the oldest person in the household. So I'll walk through the first results slide here just to walk through how this looks. So you can see here, 1939 again is this line in the middle. If you're born on the earlier side, in terms of years, your drug coverage is better. No deductible, 1.25% max. If you're born after 1939, 2% deductible, 3% max. So on the right is younger individuals. This chart shows average fair Pharmacare paid expenditure. So this is how much the public drug plan contributed toward the drug expenditures for these individuals. And you can see here that there is a rather large and rather precipitous drop right at 1939. Again, not unexpected, given that we're charging a deductible on the right-hand side of the chart or not on the left. So this is the drop of about $206 in public drug expenditure at the threshold, which works out to a relative drop of about 28%. So a really massive savings for the public sector, moving from someone who's born in 1939 to someone who's born in 1940. Now, we expected when we went into this that this difference would translate into a difference in actual total drug expenditure. And we're quite surprised to find that it really didn't. So this is average drug expenditure. So this is total. This is including everything that's paid for by the public sector and by individuals, either by themselves through out-of-pocket expenditures or through a private drug plan. And you can see here that there's virtually no change across that threshold. The estimate's about a $6 drop, and it's highly not statistically significant, and it works out to a relative decrease of about 2.4% if you work it out. But it's tiny, and the confidence intervals go from about -65 to 55. So it's a huge range there. In terms of physician and hospital visits, we found absolutely nothing. So this shows you physician visits, again, like virtually no change across the threshold. And this is hospitals. Again, as people get older, their hospital expenditure rises quite precipitously. So you see, we fit this with a quadratic term to better fit the shape of the data. But again, no gap across the threshold. So in terms of the interpretation from this paper specifically, this is a local average treatment effect, as all regression discontinuities are. And so this is the impact of a 2% of household income deductible on individuals born between 1930 and 1940 with household incomes between 15 and 30. I only sort of draw that out just to make it clear how narrow an estimate this really is when you get to it. Like the method here, like of regression discontinuity, is really strong and a good quasi-experiment, but the actual thing that you're measuring is quite narrow and quite precise. And the estimate was, as I said before, negative 2.4%, not statistically different from zero. So we moved on from this piece to think about lower income households as the next way to tease this out. And so this piece was published a year later in CMA Open, similar data and similar methods. So I won't go through them in great depth. But the difference here that we focused on, we ignored enhanced coverage. So we didn't look at the households born before 1939. But what we looked at was these two thresholds here that happened at $15,000 and $30,000 of household income. You can see here, if you're in this group under 15, you go from no deductible. Once you pass 15, you go to a 2% of household income deductible, and then you go to a 3% and a maximum of 2, 3, and 4. So you can see as you cross those thresholds of $15,000 and $30,000, your drug coverage becomes less generous, at least on the public side. So those then, of course, became our thresholds, and our forcing variable in this case is household income. As with the difference between enhanced coverage and regular coverage, there were big differences in how much Pharmacare paid toward drugs for these households. So you can see here, this is the group with no deductible under $15,000. So this is 15K here. There's 2% deductible, 3% deductible. That drop there is about a $60 expenditure. I'm going to remind you that in relative terms, we're dealing with much younger households here, so it's not a sort of direct comparison to that $200 from before. But this is a drop of about $60, so it goes from sort of the 220 range to about the 170 range. And a smaller drop here. Again, not surprising that the public sector pays less when the coverage is less generous, when households are responsible for that deductible. And in this case, when you go through and look at actual total drug expenditures, you can see that actually does translate into a difference in drug use. It's not huge, but it's present. It's a drop of about $26 in total drug expenditure across that threshold. And then this is a drop of about $6. So it appears, at least from the estimates that we got, that moving from no deductible to 2% does matter. It drops drug expenditures by about $26, which we're saying to about a 7% drop in drug expenditures. And this second threshold, that $6 is much smaller and not statistically significant, and $6 is a much smaller percentage change. We did a bunch of sub-analyses in this second paper to look at where this might matter, and those results of a drop at that $15,000 threshold persist across a whole bunch of places. So it persists across age groups, households that have kids versus no kids, men and women. Men are actually more responsive to the deductible than women. Drug types, so generic versus brand, it still shows up. And then we divided into an essential versus non-essential list using the St. Michael's clean meds list, found a difference there. Where the results do differ is across Pharmacare benefit status. So if something's a Pharmacare benefit, there's a big effect of the deductible. And if it's not a benefit, there's not. Again, not surprising. When something's not a benefit, the public drug plan doesn't contribute toward covering it. So you wouldn't expect an impact there. So like our overall interpretation for these two studies, and we worked on these pretty closely with the Ministry of Health, was that the deductibles definitely reduced public spending, no question. And they reduced overall drug use, but really only for those households at lower income levels. And A couple of big limitations. Obviously, I made reference to the local average treatment effect earlier, which is a big deal. We also have no information in the data in BC on private drug coverage, which is a huge omission. I would love to be able to stratify these results by households that have private coverage versus those that don't, but unfortunately, we're not able to do that. So our recommendations to the ministry, when we talk to them about how they could change the drug plan, and there's a whole backstory that I can talk to you about when the Green and NDP got elected as coalition government and what they wanted to do. But the outcome of that was that they wanted to make some changes to improve the drug plan. And our recommendation to them was twofold. It was raise this $15,000 deductible. So they put this into place in 2003, didn't index it to anything like inflation or anything like that. So it had remained at 15K, which in real terms means it's getting smaller and smaller over time. So first we suggested move that up, give more households access to this no deductible coverage, and think about adding more thresholds, because this, if you recall, for these households here, it didn't seem to make a big difference if you came across. So essentially our recommendation was add thresholds here, make these higher income households pay more, use that money to provide better coverage to those lower income households. They listened to part of that advice, but not all of that advice. And in 2019 announced changes to the budget. So this is from the government's budget document in 2019. And you'll see that what they elected to do was eliminate the deductibles for families with incomes below $30,000. So in terms of the plan, they essentially took the deductibles and co-payments away for all of these households. So there's no longer any cost sharing for that group. They did retain some co-payments here, but this group essentially went to zero. They took away all of the expenses in total. So this piece here is really what we focus on in the last analysis that I'll share with you, is what happened to these households in this 0 to 15 band when the co-payments were removed completely. And just to give you some context for where that question comes from, like this is also at the same time when discussions about national pharmacare were really starting to ramp up again. So this was around the time when Eric Hoskins was leading the advisory council of the implementation of national pharmacare, and the Trudeau government kept making noise about doing something about drug coverage. So the interest in seeing the effect of moving these low-income households from having to pay something to having to pay nothing was of real interest to us at the time. So the last paper I'll share. So Kartik Sharma was a master's student of mine, and so he led this analysis. We just published this earlier this year in health policy. And just as a reminder, we looked at this group right here, where the co-payments and deductibles were completely eliminated as a consequence of that change in 2019. We used an interpretive design series, which has a lot of like methodologic similarity to a regression discontinuity. And so the design here is that you're comparing longitudinal trends before and after the policy change. So you can think about an ITS as being a regression discontinuity where time is the forcing variable. So the assumption here, of course, is that the existing level and trend in the outcome would have remained the same. So if you look, this is time here. So in our example, this would, of course, be 2019, where all of those co-payments and deductibles were eliminated for the lowest income households. And this would be drug expenditures or any of the other outcomes we looked at. So the assumption is then any trends that you observed in that pre-intervention period are going to continue. From that, you can form this counterfactual, and then any changes you observe essentially denote the effect of the policy. So if you see a level change or a slope change, you can estimate those things to get some idea of what impact the policy change had on the outcome that you're interested in. So in the Sharma paper, this was published in 2025, it was accepted in 24, but we'll just modify that there. The design, again, was we studied administrative data from BC. So same data sets. We used PharmaNet, the medical services plan data and whatnot. And we leveraged that policy change in 2019 that eliminated all co-payments for the lowest income households. And the outcomes we looked at were the number of prescriptions and expenditures. So that's what I'll share with you. The place that this study presented us with a little bit of difficulty was actually narrowing down which group to look at. If you look at income data, particularly at the lower end of the income spectrum, um, folks move a lot. So they move from one threshold, they would move from one group to another, their incomes would go up and down, they would move from the group under 13 to above. So they would go from having a deductible to not having a deductible and then back again over these periods, even over 1 or 2 years. And there's honestly not that many households in BC that have incomes that are that low who are not also on social assistance. And because BC provides full coverage for households on social assistance, essentially we were limited to the households that didn't have that coverage. So I'll run through this survey. You can see, so patients were registered in the Fair Pharmacare program. We started with 2.8 million patients. We then excluded a few groups. We excluded patients using medications for hepatitis C, because around this time was the time when Sovaldi and Harvoni were leading to very high drug costs for particular individuals that were more or less one shot. And so we wanted to avoid a lot of the issues that we had analyzing with those people in. Anyone registered another public drug plan, so that would include those households that had social assistance. You then get about 2.7 million. We then excluded folks that weren't enrolled for the entire study period, patients who switched analysis groups, so they went from having a copay to not having a copay or back, and patients with incomes between 13,750 and less than 45. And I can explain in depth why we did that, but that group had their deductibles eliminated, but their co-payments remained. So they wouldn't really tell us anything about moving to having no co-payments whatsoever. So you can see that leaves us with about 829,000 individuals, 820 of whom are not having their co-payments eliminated. They're the control group, and we end up with an intervention group of about 9,000. So once we put all of these restrictions on place to try and narrow down to a group that we were interested in, we ended up with 9,000 individuals. So again, a comparatively small group, but we really wanted to emphasize internal validity over anything else here, to make sure that we were really focusing on those households that were consistently in one plan the whole time and would have had the biggest impact from from the policy change, or not the biggest impact, but sorry, the most consistent. Like, they didn't go in and out of having that the benefit of that new policy. So these are totals, not Fair Pharmacare totals. So this is mean drug expenditures in the different groups. The green here is the control group. So these are households with incomes over $45,000, and the blue's the no co-payment group. So this is the group that went from paying something before on public coverage to not paying anything now. Using this as the counterfactual, of course, leads to us to assume that the blue group would have rose a little bit. Whether or not that's the right counterfactual is an open question. We played with this or we sort of hammered at this for a long time. There was a number of drugs that came onto the market around 2019, aside from hepatitis C, that were also quite expensive. So we're reasonably okay with this, but I'm certainly open to having the discussion about whether or not that upward slope is a reasonable counterfactual. But as you can see in the no co-payment group, things hovered about an average of $25 or $26. And then you can see that there was an increase here. It was an increase of about $4. So $4 on 26 is an increase of about 10% or something in that range. So there was a statistically significant increase in the number, and it was consequential. But again, we're on a small base because these individuals were not using a ton of prescription drugs to begin with. And in terms of the number of prescriptions, you see the same sort of effect, although a much cleaner control line here, which is very consistent over time. And then you do see this uptick in both the level and the trend in the number of prescriptions that these households received. In terms of where the effect actually occurred, it's kind of all over the map. So this is broken down by ATC groups. And this we just did as a pre-post because we don't have enough sample to do these individual ATCs as interrupted time series numbers here. And you can see that there's huge increases in both the intervention and control group in anti-neoplastics, so cancer medications. And again, this elusive, what I referred to earlier, is a lot of expensive drugs coming onto the market. And here you actually see a bigger increase in the control. But in a lot of the classes like alimentary tract and metabolism, so stomach and whatnot, respiratory system, you can see changes here where numbers went up by 40% in the intervention group versus sort of 2 or 3 in the control. So the changes weren't just concentrated in kind of one type of medication or one group. We saw increases in cardiovascular, nervous system, respiratory. So you see them kind of across the all of these different classes of medications. So just quickly interpretation here, eliminating deductibles and co-payments increased total spending and prescriptions, and it had impacts across numerous drug classes. It didn't seem to be focused in any in particular. Our limitations here were clearly we have a small intervention group. 9,000 people is not a lot to run an interrupted time series with. We were happy to get the stability we did get in the in those numbers, but again, it limited us to kind of thinking about big aggregate numbers as opposed to really small kind of specific outcomes that we might be interested in. And again, here we have no information on private drug coverage as with the prior studies. This is something that's a gap in every coverage, in every province when you do drug utilization studies, and one that I'd like to find a way to surmount. That said, households under $15,000 are probably the least likely in Canada to have private drug coverage. And also, there wasn't really any shift in private coverage that was timed at the same time as the change that we looked at in 2019. So I don't think it will bias us here, but it just does limit us in terms of our ability to look specifically at the group that would probably benefit the most, which are those that are paying all their drug costs out of pocket, aside from what the public plan covers. So that's what I have in terms of my slides. I'm happy to get into any questions that you have or discuss any other issues that are even like related or tangential. So thanks very much for your attention.
Okay, thank you so much, Dr. Law. So we now invite attendees to use the Q&A function in the software menu. Drop us a note in the chat if you don't know where to find that. And anyone who has further questions that we weren't able to get to today is encouraged to email noah@ihe.ca. So I'm going to go to the Q&A and we'll start running through some questions. First couple are from me. We'll get rolling and hopefully people will continue to add them in. So my first question is that I know you've had a lot of success working with policymakers so that your research is going to have a direct policy impact. So from your experience, what are the most effective ways for researchers to ensure that their evidence is actually used in policy decisions?
Yeah, I think this is a tough question. It's one that folks ask me a lot. I would suggest there's a couple of so I'm gonna go through 3 different things that I think about a lot when people do ask me this question. So the first is about building relationships, and those relationships will be with the folks who are making the decisions, but also the individuals like within the drug plan who are doing the management, who are thinking about these issues every day. So the first study that I noted here showing that drop the second study, sorry, that showed that drop at 13.5. This was something we had talked to about the ministry, and the ministry referred to as their notch effect. They'd never actually like calculated what it was or used any rigorous statistics to look at it, but they knew it was there. And it was something that was of interest to them. So that overlap between their interest and mine, and that relationship I built with them, allowed us to do that work and to tease it out. The other aspect that goes into relationships with government in particular is don't surprise people. That's a mistake I made earlier in my career. I released things without flagging it for individuals in the public sector that would be affected by it, and that came back to haunt me certainly in a couple of big instances. So that's the first. The second is design your research questions to be policy relevant. So think through, back off the research question and just exactly what you're going to be doing from a research perspective to think about what it is that might actually be actionable. And there's always usually some overlap there. So in these cases, it's like, what are these deductibles doing and what policy change would you recommend out the other side? Because the policy that follows from some of the work isn't always obvious. And And sometimes it happens and sometimes it doesn't. And the third thing I'd recommend is be patient. Like these things take a long time. I worked on these studies for several years, and a political window of opportunity to have some influence and have some promote some change came about through that deal between the NDP and the Greens that I referred to. And the government at that point was looking for a way to improve drug coverage without spending an absolute fortune, and eliminating the deductibles for a comparatively small number of lower income households was fit the bill. So the fact that the research base was there, the ministry knew it was a problem, and the window of opportunity opened was fine. Not all the stuff, there might be obvious policy implications from some of the work that you do, but it doesn't mean that the window of opportunity or the appetite for it's going to be present. And so sometimes you do play that long game in terms of thinking about where policy is going to be in a few years and what you can do to help to inform that.
Yeah, no, that makes a lot of sense. Thank you. So the next question is from Sasha Van Catwick. He's wondering, were there any opportunities to appraise the appropriateness of the prescriptions? And then he goes on to say, assuming not, what is your read on how likely that is to impact the interpretation?
Yeah, it's a great question. The only thing we really did is do that differentiation between essential and non-essential. We have no indication in Pharmanet about indication for use, and that would be similar in the other drug data as well. So you can't tell if something is being prescribed off-label or if it's being prescribed at a dose that's inappropriate, or those sorts of issues that you might want to tease into, get to dig into appropriateness. So we shied away from it a little bit just because of the burden of classifying thousands of drugs into it and not having really any insight into why they were being prescribed. Can you repeat the second part of the question there again, Aaron? Because
yeah, for
you're
sure.
correct. Assuming it's not.
What's the likelihood that it's going to impact your interpretation?
It's a great question, and one that I wish I had a better answer for. Not being able to differentiate them makes it really tough. I mean, if you look at the cost sharing literature writ large, like all the way back to RAND, and those patients tend to be relatively poor judges of appropriateness and quality, and co-payments tend not to be great at just eliminating the kind of less necessary or less important things. But I can't tell you anything about it here because we didn't go into that.
Okay, no, fair enough. Okay, so our next question is from Dr. Deborah Marshall, and she says, thank you, Michael. As you illustrated, there is some uncertainty around the data, which is often limited, and causality with these analyses, and to what extent and how do policymakers respond to these types of research questions? And then she wants to second my question on effective ways. I think you already answered that.
Yeah, I think there's always issues of causality, and there's always discussion of that. There's anything from folks like me who will tell you that you can get causal results from observational studies to folks that are just about ready to write off anything that's not a randomized trial, and everything in between. I think some of the advantages of these two methods in particular, when you use the regression discontinuity or interrupted time series, there is a lot of sophisticated modeling that goes on behind the scenes, and there's a lot of we're dealing with between person correlation, we're dealing with autocorrelation over time, we're dealing with multiple measures, we're dealing with all sorts of stuff. You'll notice I didn't present any of that. I can talk to you about it, but I gave the very sort of light interpretation, and that's the beauty of these methods, is that I can show someone who's a policymaker a chart that's an RD or an ITS, and they can understand it quite quickly and pretty easily. So in terms of response, it's easy to get folks to understand. I mean, what they do with it is going to be colored by their position, their interpretation, their politics, their incentives and whatnot. So that's the tougher part, is then going from that, okay, I understand, and now I'm actually going to do something about it. The ministry knew about the notch effect for years, and in the governments that preceded the NDP government that made the changes to the budget, it just kept they kept the status quo. And I'm not sure if that was a conscious decision or a not conscious decision, but it certainly wasn't any evidence of change.
Okay. Thanks for that. Our next question is from William. He says, amazing presentation. Can't get enough of those ITS and regression discontinuity graphs. Yeah, they are great for explaining things really simply, and they're really nice to look at. If I was to put on my CDW hat, I would ask about the risk of moral hazard. Are these patients only using these prescriptions because they became free or because they needed them but can't afford to afford them previously to the policy change? And then he goes on to say, could we look into this further with data on medications that were prescribed by physicians but left unfilled pre-post? And then could we simulate the health impact of patients taking these medications? Lots of questions.
Okay. Yeah, no, these are all great. Thanks so much, William. I think, okay, so on the first, the CDAO had moral hazard. Sure, I'm sure there's some stuff in there that where the increases were, as what one might categorize as less necessary. I'd probably also argue that there's some in there that are as necessary. As I said earlier, a lot of the cost sharing literature suggests that individuals are fairly indiscriminate in their ability to differentiate the two. So it doesn't. I don't have an enormous amount of faith. The other thing that I would say is that most people don't take prescription drugs in most instances because they want to or desire to. Like they're taking things that limit or control disease because of a condition they have. So channeling my Bob Evans hat, because I was at UBC for a long time, he would tell you that people aren't using healthcare because because it's free. They're using it because they need it for their health. The other thing is, I would also suggest there's lots of ways to limit prescription drug use, and you can use all sorts of different formulary measures that are a lot more refined and a lot smarter than the kind of blunt hammer of a copay, particularly for a lower income household. Data on medications that were prescribed by patients but left unfilled is a wonderful question. So we did a piece that one of my students, Seraphine Zaitouni, led, where we linked the BC admin data, so the dispensations, to actual prescribing data from an EMR using the Sept database. And about, I think it was 17% weren't ever filled. So it's a big number. The trouble with it, for the purposes of this study, is that the number you can link to EMR, so the number that you can actually look at from a prescribing perspective as opposed to a dispensing perspective, is really small. And we already have a small group. We already have 9,000 people. We don't have access to their electronic medical records for the most part. And so the subsample in which you could actually do that study would be very small. I do agree with you that it would be really interesting if you could pull it off. I'm just not sure that technically you could. We certainly couldn't with the data that we had available to us at the time. Final question, simulate the health impact of patients taking these medications. I'm sure you could, and you're way outside my wheelhouse as an observational study person at this point. I don't do simulation work, but I'm certainly open to the idea and talking about it, because I think it would be an interesting add-on to this. With 9,000 people, it's almost, I think it's pretty much impossible to think that we're going to be able to pull any health impacts out and really need anything, given that the increases were across a whole bunch of different drug classes with for different folks. So I like that idea. It's just not one that I would personally be capable of doing, given my skill set.
Okay, awesome, thank you. And on the simulation thing, I was also kind of thinking around that question of the private drug care plans. Might be a way into that through simulation as well, kind of showing what might be covered for different prescription patterns and what we know about the private drug plans.
Yeah, I was thinking about this as I was presenting. If you look at results for the Canadian Community Health Survey, low income, about 60% of Canadians have a private drug plan. So it's a fairly significant number. if you look at higher income groups, I know the number for higher income groups because it comes to mind immediately. It's like it's in the 75% range. So it definitely does kind of track with income. I just forget how low it gets at the lowest income
Right.
households, but it's certainly well less than half would have private coverage. So
Yeah, fair enough. Small group. Okay, our next question is from John Sproul, and he's asking if there's any links to individual health outcomes or system impact related to expanded expenditure, and also are we assuming that prescribed means actually taken?
sure.
This is a little bit related to kind of this question later or lower in the conversations about spillovers as well.
Yeah. Individual health outcomes or system impact. The only thing that we touched on here, John, was the two charts with overall physician costs and overall hospital costs that I showed you at the start. We did sort of venture into looking at specific drug classes in the first two studies, thinking that we might be able to do it. It's amazing to me how quickly the data falls apart when you start to tease it out that way. Like if you limit it to folks with cardiovascular disease or hypertension or a particular class of medications, those really lovely like smooth lines I showed you become very, very noisy very, very quickly. And as soon as they become noisy, of course, the statistics start to fall apart. So unfortunately, we couldn't tease anything out with a particular class. And that's what we would have wanted to do if we wanted to look at health outcomes, because I would have wanted to limit it to something particular. So in the case, like, are you using your antihypertensives more and are you getting fewer MIs? Are you getting fewer hospital days or anything like that? Unfortunately, it wasn't enough data to do it, which is shocking given that we had everyone in BC over 10 to 12 years, but it is what it is. We presume prescribed means actually taking, absolutely not. And we have good evidence to the effect that that is not the case. Adherence to most prescription drugs, especially for chronic conditions, is pretty poor. And refill rates on stuff that you would expect people to refill are really low. So I suspect that you're probably alluding here to the idea that folks are filling these and not completing them. I think that's true. I think it's irrespective of whether they pay for it or not.
Fantastic, thanks. Our next question is from Leslie Sorrell. Have the findings of the ITS study had any impact or changes / refinements to current drug plans or ongoing conversations with the ministry that you can talk about?
Yeah, I think, BC has done a couple of things in recent years. So we've certainly shared these. They're familiar with them. There's ongoing discussion about the deductibles. I've been harassing them to index inflation index them for a long time, because I think the fact that they don't is just, it essentially has the effect of making drug coverage get worse over time. In terms of changes since 2019, most of the changes in BC have been oriented more around making particular classes of medications. So in 2023, BC made contraception available in the province free of charge. And we have a whole line of work looking at the effect of that. And we had a piece in the BMJ earlier this year that Laura Schumer's led, that I was last author on, looking at the impact of of BC's contraception coverage subsidy. And they've now signed on with the federal government for national Pharmacare. So we're going to be starting to cover diabetes medications that are on the federal list. And I will point out that that list is not inclusive of a lot of different diabetes medications. But they are now going to be free of charge as of early 2026. Other provinces have done the same as a result of national Pharmacare. So Manitoba and PEI and the Yukon have all signed on to that. And apparently we hear from the news that the government is now open to signing more of those deals. So I would expect that you might hear more of that coming forward in the next while. So there hasn't been further changes to the deductibles, but there's certainly been further changes in terms of thinking about individual drug classes. Oh, and I'll add, in BC, they're using the money that they're saving from contraception to cover menopausal hormone therapy universally as one of their next moves. So both contraception and MHT will be fully covered.
Very cool. Yeah, I did see that in the news this morning. So it sounds like there's lots to come in this space. Another question from John Sproul. Are there any new things you can do with AI and data analysis that you're excited about using in your future research?
Oh, I mean, John, that's like $1 million question. I don't, uh, I, I haven't gone deep down that. I've had some students use AI with prediction algorithms for particular diseases and whatnot, but I have not gone deep down that rabbit hole at this point. And I feel like you and I need to get together and chat about that to see if there's any overlaps there, because I know it's an area of interest for you.
All right, sounds good. With that, I'm not seeing any further questions in the chat. Dr. Law, did you have any final closing comments you'd like to make?
No, just thanks for having me. And now that I'm based at the University of Calgary, I'd be happy to make any other connections. So michael.law@ucalgary.ca if you want to be in touch.
All right, thank you so much for your presentation, and thanks to everyone online for attending. Our next seminar will be presented by Dr. Kate Johnson and is scheduled for November 19th, 2025. So please visit NOAHE.ca to register for any upcoming sessions and to subscribe to our mailing list for NOAHE events and opportunities. Thanks again, Dr. Law. Thanks, everyone.
Thank you.